Yeah, so I think most of my quite a bit of my insights have been covered by Himaji. And before I start, let me thank Himaji Chaudhary for including me in this course, which actually, as you were saying, the program it's been very popular and doing very well. And the Honda Public Society for the opportunity. So we would prefer that our post-op cases look like this and not a disaster like that. And what are my indications for taking up an end of case for partial vitrectomy? How much vitrectomy do I do? What one should be doing in the partial vitrectomy? So I think this has all been born into. These are the various drugs that are available, and you must have a chart which is available. This is a folder chart by CIPLA, which we normally keep it in the operation theater. And I think this has all been discussed as to what are the organisms. I thought I'll just mention about the blood-related endophthalmitis. These are the organisms and the risk factors. And these are the stages in a blood-related endophthalmitis, where again, injections and subsequently vitrectomy is required. We must go through the guidelines of the AIOS, and this is just a small video of intravitreal injection device, which has been made by me, which actually helps you to give an intravitreal injection. It's if you have to hold the eye and give an intravitreal injection, you may cause scaling of the conjunctiva, but you can fix the eye with a device, and there is a opening present here, which is actually an oblique entry, so that you get a valvular entry port, and once you keep it for a little while, you could actually do a paracentesis is required, and once you remove it, it's a pristine conjunctiva. So the intravitreal injections, when not to give is when you have a coexisting retinal detachment or a choroidal detachment, you may have to go in for the vitrectomy immediately. When you have a virulent infection, which is vision field only, or you have given an intravitreal injection and it does not work, then you should go ahead with vitrectomy, or you're suspecting a fungal endophthalmitis, a phlegmatic endophthalmitis with a heating intraocular foreign body. And as was mentioned earlier, you do a core vitrectomy, or as much as is possible. We are not here interested in creating a PVD, but if you have to in certain cases, then you may need to put in a silicone. Now, how does vitrectomy work? It gives us material for culture, it reduces the toxins and organisms, it cleans the media, it allows uniform distribution of the antibiotics, and you must remember the final fight is with antibiotics in the body's defense mechanism rather than vitrectomy alone. Now, I think Himaji did bring out this, and we should realize that in Indian circumstances, there's a higher incidence with the gram-negative bacillus as compared to what was reported with the EVs. And we must always remember that we have to have 1 gram-positive antibiotic and 1 gram-negative antibiotic for the intravitreal injection. Now, these are the indications which have already gone before, that you have visual acuity down to light perception, virulent infection, progressive course despite initial intravitreal antibiotics, delayed onset endophthalmitis, fungal recurrent endophthalmitis, endophthalmitis with detachment of corneal purr for retained intraocular foreign body, no view on indirect ophthalmoscopy, always in classification of vitreous and macular pucker in subsequent stage. Now, Himaji did mention about how you take the sample as you put in that connector, and you can aspirate, and you can do a cutter in aspiration. It's not going into the machine, but going into the syringe. This is just, I run the video simultaneously. sorry for the music, but sometimes you have to, you have to put on an ECM antenna. There is a pupillary membrane which you need to remove it. This is done under peripheral anesthesia. And once we remove the pupillary membrane, we will have a good view of this is a little older video. So you have a good view of the fundus. And once you get that, you should be able to assess how bad it is. I've had two situations where once we took the patient for vitrectomy, we removed the pupillary membrane and we found that the vitreous was reasonably clear. We decided not to do a vitrectomy, gave the intraocular antibiotic. So every step we must try to evaluate and cross-check and then proceed further. But essentially, after having done this, we should put a 6 mm infusion cannula. And let me just push it further. So when we put in a 6 mm infusion cannula, which we used to do it with a 20 gauge thing earlier, and this is put in. You identify the opening, and then you go ahead and do a fold vitrectomy. The fold vitrectomy, no, these days we use the triple cannula system, and the most important thing is before you start, you must identify the cannula. The vitreous is cut as much, so you are identifying the cannula, and then you go ahead and do the vitrectomy. It works out pretty well. We're able to see the optic disc, and once we have achieved those goals, cut as much vitreous as possible, give intraocular antibiotics, and you are done. So these are some of the cases where patients before presentation, 3 weeks after vitrectomy, 4 weeks after vitrectomy, visual acuity, like in this case, improved to 612. Here the visual acuity is PN plus improved to 636, and it takes time. These are some of the examples of patients who had a vitrectomy with a P. acnes, talking of the P. acnes, where we give an intracannular vancomycin and intravitreal. And this is an example of 4 weeks after passing a vitrectomy, and these are some of the cases of fungal endophthalmitis, where eyes may have more signs than symptoms. These are cases of chronic endophthalmitis with thick isothion, which may not change its position on tilting the head. And these eyes typically have minimal pain and condition. Exudation is predominantly limited to the anterior segment, and the patient underwent AC wash vitrectomy, intravitreal injection of voriconazole, intracameral injection of voriconazole, and one of the cases had an explantation of the eye. And this patient with such a bad fungal endophthalmitis is equal to 6/9, 6/36, 6/36, did pretty well. This is about 4 months later on. This is another case. You can imagine this patient, we had to clear up the anterior chamber, did a radical vitrectomy, and used silicone in this case. Now, fungal endophthalmitis can be numerous organisms. This is just an example that we had a patient who presented with an acute onset endophthalmitis with Aspergillus niger. Usually presents as chronic, but can present as an acute, and a case of pseudoerythema boydii, which again was diagnosed. And it's important never to give up these cases. This is what I've taken from the Dasis presentation, which was reported, where a 77-year-old man presented with total loss of visual 3 days after cataract surgery. The eye was congested with a visual acuity LP, underwent vitrectomy, and patient finally improved to 20/70. So end off with the retin detachment. You have to use silicone oil. You have to do a radical vitrectomy. You have to do laser photographs and post-operatively. And you need to give intraocular antibiotic injection in the peripheral space. End off with corneal perforation. We have done this in 2 cases where the cavity prosthesis was used, subsequently with therapeutic PK. And you sometimes have to explant the eye and try to sooner. These are some of the reported cases where you can do a corneal tear repair within endophthalmitis and other cases. You can also have endophthalmitis after a vaccine injection, after Orbidex, and these cases, this would require intervention of the technique. If there is a little time, can I show 2-3 interesting cases?
We have time till 4:25. So now it
Yeah,
is
so we have about 4
4:20.
minutes.
Yeah, yeah, yeah.
So
Yeah,
let me just quickly show.
yeah, sure, sure,
Yeah,
sure.
yeah. So this was Ashish Lal had a case, and this patient had come with type 2 diabetic intravitreal injection of Avastin, which is enraged. Patient developed underwent PPV, received intraocular antibiotics. Patient went for a second opinion, had come undergone a second revitrectomy, which a sample was sent for PCR. And at this stage, the bacteria is fragilus, and patient received imiquimab, responded negative. So it's very important to have the correct organismal diagnosis, because that gives us a better thing. This is another patient whose cataract surgery, Mancotazobactam, vascular nephrectomy was done, microvalue was negative, vitreous sample was sent for PCR, new pseudomonas. So once we got pseudomonas, the patient status is persistent, and again, organism diagnosis saves the situation. This was the thing from. So let me show you one case which I have followed personally for many years. Patient underwent cataract surgery, came to us and was treated elsewhere. We received intravitreal bevacizumab, and subsequently developed endophthalmitis. Was treated. We did a vitrectomy. Subsequently, patient had a recurrence. Was treated elsewhere with 14 injections of Vancomycin. Was cultured and PCR negative. Had a PET CT done and received methotrexate. Came back to us, and we thought maybe it's a masquerade of chronic post-op endophthalmitis or uveitis. So these were the options. But the patient was already vitrectomized. We needed a sample. So we started thinking, let's think out of the box. We have to get this done. So what I did was took a long needle, a 26 gauge needle, bent it around a 50 cc syringe, created an opening, created a cannula out of this needle, went to the zonular area, and
Sorry to interrupt you,
sample
doctor.
was
We
yeah,
have
this is
already
finishing.
time up.
So, and this is how it was done. It was sent for PCR that grew different organism into different labs. It was treated and patient did well. So the take-home message is timely and judicious vitrectomy, documenting all the findings, talk to the patient, do not hesitate to take opinion and refer the patient if required. Always use a good cutter, use a 6 mm infusion cannula, do a core vitrectomy. PVD induction is not necessary. If it is there, great, and we should reduce the suction to avoid damage to the retina. Thank you, sir.